see. I'm sorry. When it starts, can you see John's here? So when you take it,
And I would say just a reminder, the mics are live.
Okay, we're gonna get started here. They're looking at, we've got two different we have the webcast and then we have the Zoom for a couple of members. So just give me 1 second here. They're gonna. Hopefully, we have Noah and Katie joining us via Zoom. So we'll see if this works here. And again, we have agendas and the PowerPoint printed if you guys need it up here. They said they're going to YouTube now, so let's see. It's weird though, because I don't see Katie and. Look, he said he can't do it. I think Katie's. Okay, so it's weird that we can't see, Katie said she's on, but it's weird that we can't see her, or I can't see her on my list. Okay. So Katie, you can, I think you're on. If you can hear me, maybe give me a thumbs up or something. I'm hoping Noah, if you guys are able to talk, let me know. They said they can't talk as attendees.
On a Zoom or
Yeah.
on YouTube? The YouTube they can.
Okay, they're sending, Katie and Noah, if you guys can hear me, they're sending you panelist links. So we'll go ahead and get started, and they will send you a panelist link, use that, and then I'll email or chat you guys when we get started. So we should be able to get you guys to be able to use your voices during so we'll go ahead and get started. I'll take attendance for Noah. I do not have the attendance in front of me, but I think I can go off memory. Or what we can do is why don't we just go around the room, see who's here, and then I recognize if I think people aren't. So that might be better. Thank you. And I'll just keep notes myself. Okay, if you don't mind, do you mind starting us off?
Hi, I'm Derek Nord, Indiana Institute on Disability.
We have some new members too, sorry, so just.
No, that's okay. Indiana Institute on Disability Community, Indiana University.
Karen Brummett. I'm from IPMG. I represent case management.
Sean Fulton, the ARC.
Kathy Robinson, Deputy Director for DDRS.
Kim Han, family member.
Loretta Springer, family member.
Kate Barrow, Indiana Governor's Council for People with Disabilities.
Kyle Ingram, Director of Policy and Strategic Initiatives for DDRS.
Carrie Lee with Indiana Family to Family.
Hi, I'm Heather Dane, Chief Program Officer with Leeds.
Good morning, Ann Titus with Benchmark Human Services.
Good morning, Holly Wemstadt, Director of the Bureau of Disability Services.
Hi, Matt Rodway, the Ombudsman.
Kim Dodson with the ARC of Indiana.
Kelly Hartman with Indiana Negotiation of Behavioral Consultants.
Good morning, Kelly Mitchell, the Director of the Division of Disability and Rehabilitative Services. And before I pass it over to Jessica, and I know you're going to do that, but may I once again welcome Kim Han as our newest family representative, and then Ann Titus as our provider representative. And you're going to speak more to.
Yeah. Well, I was gonna let them share maybe, but yes. But yeah, well, I'm Jessica Harlan York, Chief Operating Officer of DDRS. Yeah, do you guys mind just maybe sharing? Oh, Melissa, yes, Melissa, go ahead. Introduce yourself first.
Hi, Melissa Keys, Indiana Disability Rights, and late as usual.
That's all right. And we have Noah Upchurch and Katie Stafford Cunningham. Noah is the president of SAI, and Katie is it president or director? Or I don't know of NRF exact title. Executive director. Executive director of NRF. And they are joining virtually. They had to join virtually, and they're working on. They can hear us, but they just can't speak. So they're going to get a panelist link in just a few. So I don't know, Kim, do you mind just sharing a little bit about yourself? And you definitely can probably do better than I and sharing an Ann after.
Sure. My name is Kim Han. I am the mother of a 28-year-old daughter with intellectual disabilities. She's a complicated girl, keeps us on our toes. We've lived in Indiana most of our life. We lived in South Carolina for a couple of years. My husband worked for Caterpillar, and so we were there and back. So we've had a lot of experience with disability services through the years, really from birth to 28, minus a couple. She currently attends a day program 2 days a week. Otherwise, she lives at home with us. And I don't know, I work part-time for a publishing company. I'm a project manager, client success manager. I help people write their books, generally kind of business books that are for a purpose. We don't really do fiction. So I don't know. We like to travel. Claire travels with us. She loves a good car ride. And I don't know. Is there anything else?
No.
All right.
Thank you for being here, and we're excited to have you.
Thank you.
Good morning again. My name is Ann Titus and I work for Benchmark Human Services. I've worked for Benchmark for 32 years, and so I've held a variety of positions throughout those 32 years. I'm currently one of our operational vice presidents, so I cover Indiana group homes, Montana supported living waiver, Missouri supported living, and New Hampshire group homes. So have some experience outside of Indiana, but definitely have spent 32 years within the Indiana system. So it's a pleasure to be with you. Thank you.
Great. Thank you, guys. Okay, we have Noah and Katie joining us. So I'm going to see Noah. Hopefully we can hear you, or if you want to go first and maybe just introduce yourself. And I did part of your job, so sorry.
I heard, no worries. I'm Noah Upchurch, president of Self Advocates of Indiana. Sorry that I wasn't able to make it in person. I'm feeling a bit under the weather, but things are looking up in terms of my health. So
Great. That's good to hear. Feel better. I know it's going around. So, okay, Katie.
Good morning, Katie Stafford Cunningham with NR. Thanks for bearing with us as we got in the right spot, and appreciate the flexibility to be able to work from home while my girls are home for our parent teacher conference day. So right in the middle of the week, it's super helpful. Love that. Anyway, good to see everybody. Thanks.
Thanks, Katie. That'll be me next week. So I feel you. Okay. Noah, do you want to, I actually got the video teed up to share the Open Futures Learning video. Do you want to share anything about it, or do you want me just to go ahead and hit play?
So yeah, this is just a video about the importance of being paid a living wage out of kind of a workshop environment.
Go ahead and hit, and I think we'll be able to hear it. Cross our fingers.
One of the big things for me is having paid employment, because a lot of my friends sort of do work for people but never end up getting paid. And people with learning disabilities have the right to be paid, but it should be a proper wage, not just £2.50, £3.50. It should be a proper wage, the same as everyone else, because they have the right to be paid and they have the right to employment. I'm quite lucky that I've been employment on and off for quite well since I left sort of higher education, really. There was only sort of 2 years where I was unemployed, but I was doing voluntary work with Commonwealth People First, which sort of built a bit of a gap for me, and it really helped me to gain experience in what I'm doing now, really. And I think paid employment for me is everything. I enjoy meeting different people, and it's not just about the work, it's about meeting the different people and sharing experiences. You know, my ex-girlfriend attended a day service, which found a replacement within a local restaurant, but they used to call on her when staff were off ill because she was unpaid. They'd call her in, oh, you do a couple hours, but she'd end up sort of doing an 8-hour day. And they'd always take advantage of her. They didn't care how she was going to get home afterwards, just the last bus had already left. She'd end up sleeping either at a friend's or going back to where she used to live in the residential care. And it is something which it shouldn't happen in this day and age. People with learning disabilities need to be respected by people, and most definitely employees. You know, they are employees as well as everyone else. And something which she used to get quite concerned about was they'd only sort of tell, oh, you've got to work this and you've got to do that. And I said to her one day, I said, Sarah, do you want to do anything? I said, if they want you to work a Saturday, I said, well, tell them they've got to pay or they will pay me, because I'm not worth paying. But it's like I said to her, I said, you're doing the same work as everyone else, but you're just free labour. And, you know, since that, I think, you know, it's all finished, but it went on for 4.5 years. She was, you know, sort of unpaid labour. And I just think it's wrong because she had to go and she had to pay for herself to go through a food hygiene certificate so she could work there. And I said to her at the time, I said, well, if they want you to have it, they should pay for it. But, you know, it's just something which, you know, it needs to change.
Thank you. Does anyone have any thoughts on that? I like that video. Noah, you found that video, so I don't know if you have anything to share about that, but it is a really good, powerful one. Short and sweet, but I think gets right to the point.
Well, and I'm sure it's something we've all heard, you know, even in our state. So it's something that resonates.
Yes. And if you guys ever have a video too, please feel free to share with us. It doesn't have to just be Open Futures Learning. I just tend to go there because I like their videos. So if you ever have a video or anything that you want to share, please send our way.
Can I? Yeah. I think one of the things for me, and I think most of you know, I came from the provider world prior to joining the state, that worked for 30 years and in the industry. And for me, what resonates is really the piece about volunteer work. And we need to be careful with that. And in that example, it really was the individual was being utilized for paid work. Someone else had been paid to do it, and they were called in to cover when there were missing employees, but they were unpaid. So I think those are the things that we need to be careful with. We want individuals to be able to explore, to discover, to volunteer, to do all the things that we all do, but we don't ever want to put people in a situation where they're being exploited. For me, that particularly resonates. You're nodding, Karen, because it's a cautionary tale. It's easy to unfortunately fall into that trap. Thank you for allowing me
No, go ahead.
to comment.
Or just assume that they'll want to volunteer instead of work, right? Or like make assumptions 100%. Okay, thank you. And also just a reminder, we are leaving the last 15 minutes open for what I call parking lot, just in case we're running over or, you know, there's something that you want to bring up that isn't quite on topic. We can save that to the end just so as you guys know, we can sometimes get off on not tangents, but move it away from a topic and then we get down the road and then, yeah, especially in person, which is great, but it just saves some time at the end. So we can keep plugging away. Okay, I am going to turn it over to Holly. Holly, I'll be your Vanna for the slides. I'll try to follow your lead. And as you guys know, we always start out, all people are empowered to live, love, work, learn, play, and pursue their dreams. Just a quick agenda. We have Holly, Kyle, just do a really quick aligning waiver supports and VR services. Obviously, we're still, we want to share that every month, even if there's not tons to share updates. Continuing just to keep that on the agenda. I'll share some information and highlight some IPPs and give a quick update on the dual diagnosis capacity building work that we're doing. And then we have the parking lot. We have the video already. Okay. And Holly, I'll turn it over to you. And you guys have the slides as well in front of you. And they were emailed as well.
All right. Good morning, everyone. You will notice that I have included the data slides because we've done some reorganization to try to streamline the data so that you can get a quick look. And it be a little more digestible for you than the 20 pages or whatever we were sending out before. So just going to spend a few minutes kind of walking through that. As you see here on this first slide, we have the numbers of individuals receiving services through the CIH at a little over 9,000, and then the FSW a little over 23,600. That is a snapshot from August 6th. Of the number of people actively in services. So if an individual is interrupted or terminated for a short-term reason, they will not show in that count. So just again, a reminder that that's a quick snapshot. The CIH applications received per year. This is just to demonstrate what we've seen in terms of the number of requests for CIH. As you can see, it was at its lowest. In this graph in 2021, we saw a spike in 2022. It returned on a downward trend in terms of number of applications in 23. The dotted line that you see, the white dotted line, is our projection. So we anticipate over about 803 applications for the CIH in this calendar year of 2024.
Can I
Next.
ask a
Oh,
question?
sure.
So the note of the decisions rendered. So with all three of those quarters, it says, you know, a smaller percentage has had a decision rendered. Does that just mean that?
You're on the next slide, Kim, right?
Oh.
It's okay. No, you're fine. You're fine. I just wanted to kind of, no, I just wanted to cue Jess to move to that slide. So go ahead. Go ahead.
Can you explain what that means?
Sure. So what that means is of the 66, for example, in the first bullet there, the first blue box, we've had 66 CIH applications submitted in Q3. Of the 26 that we have rendered a decision on, 40% or 100% have been approved. So we have rendered a decision on 40% of the applications that were submitted in Q3.
So then what happens? That's my question. So what happens to the other 60%? Surely they get an.
They're still under review.
Okay.
Yes,
All
they're
right. I just
pending
wanted to make
review.
sure that
Mhm.
Haley's got a reply back. Okay.
Oh, yes, absolutely. They are either, might have requested more information on them, or we may just not have gotten to their review quite yet. Okay.
Sorry, I was. ahead of
No, that's fine. Actually, it was a perfect segue, Kim.
It's actually a very good question, and to your point, anyone that applies, they will receive a decision.
Yes.
Whether the application has been approved or it has been denied.
Okay, and that's what I thought.
Yes.
And
when you say approved, you mean approved to go on the CIH waiver, not approved for.
Their request was approved.
Yes.
Their request for CIH was
CIH.
approved. Mhm. Yep. Good questions. And we've received we've approved 232 CIH applications this year already, and that's all categories as well. 232. It's in the orange box
Yes,
if you're
they-
looking at the screen. But again, that's all categories. Yeah.
Hey, Katie and Noah, if you guys have questions, it's Zoom. It's hard for me to see in the chat and trying to share at the same time. So just feel free to interrupt or something, because I can't really follow it, and I don't want to ignore you guys just in case.
Will do.
Will do.
Okay, so again, this is a snapshot of, how many CIH applications under all categories we've received in each quarter of this year. And the percentage with the decision rendered, and then how many of those have been approved. You'll note we did see a 7% increase in applications in all categories over in the Q2 of this year as well.
And Holly,
Mhm.
may I add something?
Sure.
I think when you look at those per quarter and you look at the percentage that have been reviewed, and Matt, I think you had this question months ago, but I think it's always worth mentioning. Because we have the priority categories, and there may be applications that are submitted under health and safety. Those are open applications. They're not screened. It's not necessarily been deemed emergent, but that's the category under which the individuals apply because they don't fit under the others. There are processes in place if an application upon initial receipt is flagged as an emergent situation. So someone's homeless, someone's in an abusive situation, there's been anything of that sort that's questionable, that gets, if you will, flagged and elevated to our team to take a quick look at it. So I don't want to give the impression that there could be an emergent situation that would linger in a review process. So there are some checkpoints there, multiple actually.
Mhm. Yes. All right.
So then how long does that review process then typically take, since there are some that are still in review for Q1?
Yeah.
It's not emergent.
Right. It depends, honestly. Again, we don't necessarily there are often times that we will request additional information, and that can look a little different. That could be our district office reaching out. That could be something from the case manager. Many of the CIH requests that we receive on the non-emergency categories and even the emergency categories like death of primary caregiver, those are very quick, right? It's a very quick submission, very quick review, very quick process. The health and safety request, the requests under the category of health and safety, we always want to make sure we're doing our due diligence to look at all the information available on whether or not that person meets criteria. So those typically do take longer because again, we want to do our due diligence and make sure that we're looking at all, that we have all the pieces to consider in those reviews. Okay. All right. Good questions. Next slide. So again, this is designed to give you a quick look. So oftentimes we talk more about the emergency categories. So we also wanted to be able to show the non-emergency categories. And the next slide actually breaks down what those are. But what you see here is that as of August 6th, we had 299 CIH requests under emergency placement criteria. There was a few of those, and again, they're on the next slide. And we had 169 non-emergency applications that we received. So the yellow box or the yellow parts of the bar graph that you see are the denied CIH requests. The lighter blue are the approved. The green is pending a decision, and then the darker blue is individuals who withdrew their application. That might be for a number of reasons. They may have moved out of state. They may have opted to pursue SGL or any other reason, but we certainly do make sure that individuals know what that withdrawal means and that they can reapply at any time should they choose to do so.
What is SGL?
Oh, I'm sorry. Supervised group living, most commonly called the group homes. Good question. And apologize for the acronyms. You call me out on that when I do that,
We need to
please.
give you our acronym.
Yes, that would be helpful because we have a lot of them.
Change.
And then it changes.
Or we say different terms.
Yeah. So, so again, this is just meant to give you a quick look so that you can see kind of the status at a glance. If we go to the next slide, you'll see the breakdown of the emergency and non-emergency categories. So I want to draw some attention to the non-emergency categories. These are non-emergency applications with a decision rendered. And it includes the count of approved or denied. It would not include pending here. The large bar graph or the large bar that you see are individuals that are coming from our money follows the person. I almost said MFP, but MFP is money follows the person and moving into the CIH waiver. And we've talked about before that our MFP program has grown. And at the end of the 365 days of the MFP eligibility, those individuals in this situation are transitioning to the CIH. I would also note that the individuals, in order to qualify for MFP, actually qualify under one of these other priority categories. So even if they didn't pursue MFP, they would have access to the CIH waiver because they would be coming out of a facility.
I've got a question on this.
Sure.
How come ESN is 0? It's August.
Because those ESN are probably the individuals coming out of ESN probably went through MFP. Yeah. The MFP does allow, the services are very similar, but it does allow for some additional activities with the district and the case manager. So we've seen that the MFP program can be particularly helpful for people coming out of facilities that where they have gotten some additional intensive support. So maybe that's a nursing home, maybe that's an ESN home.
So we don't, I mean, obviously by looking at this, we don't know how many people came out of an ESN.
We do,
You know,
now, we
yeah.
do, yes, but what we
You know what
can,
I'm saying?
I
Yeah.
think, Matt, I just started to say, your question causes me to think in future state, I'm making a note, we should likely present this because to the clarification that Holly just made.
Yeah, I understand.
MFP, money follows the person, is a funding source, not, and so really these folks are, you know, their priority because of from where they're coming, that institutional setting. So perhaps, Holly, we can rethink it, where, you know, from where, what placement are they coming, and we can report broadly about the utilization of money follows the person to support those transitions.
sure,
So we'll take, that's a good
yeah, it's
question.
good feedback.
Yeah.
And what's ESN?
Extensive support needs. So that is a small supervised group living setting that specializes in supporting individuals with intensive behavioral support needs.
It's licensed as a group.
Yes,
One
it's
person.
licensed. Mhm.
Do you only get transition dollars if you come through money follows a person? Is that right? Correct.
What do you mean transition? You mean community transition?
Community transition.
That is a service available through MFP, yes.
So that's probably why they're going that way, because you get money to set up your household.
You get that.
You can get that on a waiver as
That's
well.
available on the
Yes,
waiver.
yeah, that's available on the
That
waiver
was
as
one of my
well.
questions. That's why I was trying to.
Yeah,
Until I
the-
get right plans of care.
It's, yeah,
So
that's a
the
waiver
member-
service as well.
Yeah, the money follows the person program as Kelly noted is a funding source. But for the purposes of comparison, the services are the same as what's offered on the CIH waiver in this discussion. So they would have access to the community transition funds, whether they were coming onto the CIH, straight to the CIH or to
I
MFP.
mean, you're gonna see more institutional transitions under MFP
Mhm.
because of the enhanced federal match that we're getting.
Right.
And people choosing that as an avenue to get.
Because it's
That's
a,
a-
yeah, it's the
the
initiative
state-
through CMS. It's a demonstration project for states to improve how individuals are transitioning from facilities and to better supporting people to live in the community. So truly it is a funding source. And I think these questions have been great. We've been talking about this internally, how to make that distinction, because we like our acronyms and we throw around MFP or money follows the person. And it truly is, it's a grant source, it's a funding source. It's not a separate waiver. It's not a special priority category. The individual leaving the institution is what causes them to be priority for that CIH waiver.
So it's kind of a bridge.
For a year.
That's a nice,
Yes.
that's a nice way to put that. Funding
Yep.
bridge, yeah.
And it lasts a year.
It's impressive.
365 days.
Then it switches.
Mhm.
Truth is, a lot of people use that as a fast track to get to the CIH waiver.
How?
Not in
Well, they would qualify for the CIH
Yeah.
waiver regardless.
Yeah, but that doesn't require
Yeah.
MFP.
How?
Yeah.
Right.
Hi, so on this graph, we're looking at the number of non-emergency applications with decisions that have been rendered. How many people, I'm looking at things like transitioning from psychiatric, I'm assuming that's the psychiatric hospitals in the state. How many people with IDD are in the psychiatric hospitals? So just to have context to know how many people are applying and how many people are being approved and denied. Having some of that background. Like how
Yeah.
many people? How many would you say are aging out of DOE? I think we need to know how many people are in DOE first to know, is this a good number to consider? Or do we like this number? Or do we want to see
Sure.
increases? Same with DCS, aging out of DCS. How many of our population are in the DCS this year?
Yeah, so I think that's a really good question. I will say the numbers of individuals, for example, in DOE, those are DOE funded placements.
Yes.
So like IDTC, Daymar, TC Harris. And while we have a sense of what those numbers are, we are dependent on those kind of being reported to us or individuals already being supported, for example, through the family support waiver. Because it is possible for a youth to have the family support waiver and be
Yes.
utilizing that outside of that school setting. So,
Absolutely.
yeah.
I'm curious for the context of what these numbers are. And I know DOE posts their reports on their website. Is it possible to partner with the Management Performance Hub to do some of that comparison data?
We can certainly explore that, sure. Sure. And the DCS numbers also is changes. I do want to mention with the DCS numbers, we do work very closely with DCS on these youth that they have that will be transitioning so that we can get as early a start as possible to line up supports for them for when DCS is no longer involved.
Sometimes DCS calls you up when they turn 18 and say, come to surgery.
Yes.
And sometimes they don't get them until they're 17 and a half. So, you know,
Is there
it's
a process that's posted anywhere for transparency's sake on how that is handled, like a warm handoff process between DCS and FSSA for those services?
so we actually have a youth services position that focuses a lot, most of her time. We have someone new in that position that works directly with DCS, and that's literally every county.
I can't imagine that must be that's a lot of counties and a lot of
It's a
people,
lot,
so-
but not all the kids, thank goodness, that
Yeah.
DCS is supporting are aging out. So,
Sure.
but yes.
And so what about the psychiatric hospitals? Do we know how many people with IDD are in the psychiatric hospitals?
I don't know that off the top of my head.
Kelly?
Yeah.
Right. From working on stuff for the Behavioral Health Commission, it was between 100 and 110 at that time, so that was a couple months ago.
And I think an important distinction with that is our involvement with individuals in the state psychiatric hospitals, we are involved with them. We see them every 90 days. But until they are deemed as ready to discharge, then they're not ready to discharge back to the community, right? So we do work with the treatment teams at the state psychiatric hospitals with those individuals as well. So, all right. Let's see. I think I'm going to do a quick time check because I have a tendency to run over anyway. And then you see the emergency applications with decisions rendered. And you'll see that by far we get more under that health and safety category, but this does demonstrate some of those other categories, death of caregiver, you know, where it's, we have a very quick turnaround on those. The other thing I wanted to mention is our applications for CIH come from a variety of places, right? Other social service agencies that are supporting an individual in a situation. If an individual, for example, submits a CIH request or application under the category of loss of caregiver, and it's a situation where mom and the adult woman were living together, just the two of them. Mom went to a nursing facility. Somebody's helping or supporting that individual in completing a CIH request. Let's just say they're outside of the BEAD system right now. And they submitted under loss of caregiver, and we read it, we review it, we see mom went to a nursing home, that doesn't fit under death of caregiver. We don't deny that. We send that through the health and safety process, right? To make sure that we're reviewing and looking at the person's entire situation. So we wouldn't send that back and say, nope, you don't meet under the category you submitted under. We will send that through that process again, so that we're doing our due diligence.
And anybody, because sometimes I don't know the answer, but clarification, anybody can apply under that.
Oh, absolutely. I can apply under any category. There is nothing to prevent people from applying.
Well,
Every application is counted, whether it met a floor. It really was how every application is counted. So to your point, anyone can submit at any time for any reason
Mhm.
and can submit multiple times. So.
Yeah, there's no time limit. If someone applies and are denied, there's no time limit. They have to wait, for example, in order to reapply. Sure.
On the number of people who get denied on the health and safety, obviously that team, for whatever reason, thinks they're in an emergency situation. And then they apply and they don't get what they need. What's our typical, like, here's some other things you can do.
Yeah, so as part of that process, we always give recommendations to the team when we review a CIH request, whether it's approved or denied, right? Because we've taken a pretty holistic view of that situation. So that information is provided in writing on the actual letter now, and also discussed by the district staff with the individual or family. And I will say, just Kelly, to your point, when you started your question was teams would see that as an emergency. I do want to say we get applications that very clearly state this is not an emergency. We are trying to plan. And that's okay. Again, we're not trying to put up barriers to people requesting the CIH, but we do see a number of applications where the application itself will state it's not an emergency.
Or they'll state there's really not a health and safety concern.
Now, we still review it.
I've actually had that.
I mean, yeah, we still review it. We
But
take
we
it through that same process. But we actually do get some where they say it's not really an emergency.
Yeah, I mean, that's why I brought that up, because I know case managers that tell people, no, you don't do it. I mean, they can apply.
Sure they can.
apply.
Yeah.
So in this data, if they applied 5 times, we're gonna see that 5.
Correct.
You're gonna see
We're not
5.
Correct.
Not 1.
That would be a
So
duplicated
this is-
count.
This is
Mhm.
duplicated.
Yeah,
We may serve somebody that may apply one time.
sure. Yeah.
We then read them.
Well, and people's situations change too. So.
Yeah, and you don't want to close that.
All right. Next slide, please. Okay, these are applications. Now we're transitioning away from CIH discussion to the actual applications for bead services. So I've talked about this quite a bit, but this graph also shows that increase we saw in applications for services in 2021 because we rolled out the gateway, the beads gateway, which is the online application process. So glad we did that. But as you can see, we've continued to have a very steady growth in the number of applications we've received. We anticipate, again, with that dotted line, that we will have almost a 13% increase in the number of applications we receive between 2023 and 2024.
And is this report duplicated as well? This is just application.
This is just application.
Okay.
So I will say that we do get applications for services from people who are already on the wait list, for example, or someone in service. Maybe a youth has the FSW. All of a sudden there is DCS involvement and DCS isn't yet aware that that youth has services and they do an application. So we do see some duplication in applications. But more than, I think almost 80% are brand new people to beads.
Is this applications for CIH only or?
No, this is
That's
application for bead
correct.
services. Yep, yep.
So do you have any idea why it's 13% seems like a lot? I mean, is this more people know about it and we're better reaching people, or is there are more people here?
I think it's a combination of things. The online application really allowed us to reach more people, and that was evident really quickly in 2021 when we rolled that out because we saw a huge jump. We are also seeing, and we'll talk about this on the next slide, most of the people, yeah, most of the people applying, and on the family support waiver wait list are youth. And, you know, a number of years ago, we really got, and Matt knows this, we wouldn't, despite a lot of outreach to schools and things, we would not get a lot of applications until people got close to getting out of school, right? When the families were starting to think about what next. That's not the case anymore. We've got families of very young children applying for our services. So I think there's a lot of different things. I would also note that 31% of the BEADS applications we receive for services are in our District 5 area, which is no big surprise, but yeah, our central, I'm sorry, yes. Indianapolis area, sorry. There I go talking BEADS talk again. Thank you, thank you, thank you.
Still have to do that.
Yes, the Indianapolis area, yeah, and the donut counties. And we are most, I think 40% of the population we support is in the Marion County and the donut counties, yeah.
What happened in that time frame is when targeting of caseloads, that was the beginning of the pandemic, right? The targeted number of people being targeted for the waiver got cut in half.
Yes, we'll get to that, yeah.
With applications, those are the applications for services.
So, but the growth.
Right.
Of people waiting now.
Yes.
But that would be the wait list.
That's the wait list, yeah. So if we want to move to the next
I
slide.
think that's, but it's a good comparison. One of the things that I talk about is if you go back to a point in time when there were 3,700 applications a year, and look at the number of people on a wait list versus 9,000 applications a year. So you have to put that somewhat in perspective as well, because it's not necessarily growth within that same number. Oh.
So as we think about the applications increasing, and Karen, what you were getting to and what Kelly was addressing was we're seeing growth in the family support waiver wait list. As of August 6th, we had 8,002 individuals on the family support waiver waiting list. Again, you know, 12.5% increase in the applications we're receiving. It's of note that most people that apply for BEAD services are found eligible. So.
Yes.
It's interesting. Yes.
But I also think, and I know you're gonna talk about this, it's part of the reason that we are looking at level of care and assessment tools. And this isn't meant to say that children who are experiencing developmental delays and have disabilities aren't in need of services and the families aren't in need of support. I think it's important to note that our current system and processes were designed for a time when typically individuals with intellectual and developmental disabilities did not access services until they were late youth, adulthood, early adulthood. And so this is part of our processes need to become more current. Kim, you and I were having that conversation, and that's why we're looking at it. I think it is interesting that nearly, 99% of all applications are approved. That likely means we have some systemic issues.
And of the minors on the waiver, do we know how many are using the waiver and not just case management?
It's a lot.
Okay.
It's a lot.
It's a lot. There's not that many individuals that are just utilizing solely case management. We just pulled those numbers the other day and I don't remember the exact numbers, but.
That first bullet says waivers to 8,000. Is that based on, that chart at the bottom suggests it's closer to 11, closer to 12,000, if you just add those numbers up. Unless you
We actually, the wait list as of August 6th was 8,002.
I think it's that first bar chart.
Oh, yeah.
Yeah, you add that up. It's 11.
That's, I'm sorry.
The total is 6,000.
Yes, 6,000, not 3 plus 6, right.
Showing this is
Right.
That needs to be corrected in
Yeah.
future. iterations.
Well, I think it is right. It's showing this is at, it's not, it's saying this 3,000, that's where that number, it's not it's not wrong, it's just confusing.
It's just,
gotcha.
yeah, it's just not real clear, so.
Read, like that line is.
The 0 to 5 is 30.
No.
No, the
it's-
0 to 5
it's
is
just telling you
6,
what that number is,
6,000.
Like.
Yeah.
There's 6,000 in that whole age group.
Yeah.
Correct.
Grade bar is how many of them are.
Yeah, yeah.
Correct.
Thank you, I just want to.
No, that's okay. That's okay.
It's not-
But if it's confusing, we should work.
Yes,
through it.
right,
So I
right.
love the question.
This is,
Just a little bullet, by the way.
okay.
That's.
Yeah. Yeah, but I think what we're trying to demonstrate there is 77% of the individuals on that FSW wait list are 13 years of age and younger.
We are seeing lots of people come on the waiver. It's for the Medicaid part of, I mean, it's the.
Access to
Sure.
Medicaid.
One, you get case management, so you're working on that whole life, hopefully, working on person-centered planning and whole life, but then also the access to Medicaid.
Mhm.
Because so much of families are going into bankruptcy because they can't afford all the co-pays and physical therapy and all, OT and PT and speech. And so there is still a benefit to that because some of the other services aren't available, right? And so there is still a benefit there. It's just, and our services weren't built for children. I may have been singing this song for a long time. We may have put in a proposal for this one, but I think there is still some benefit to children being on it. We just didn't build a program thinking about children.
Yeah, it wasn't
Mhm.
designed.
Yeah.
It wasn't designed for that, and providers haven't made that switch to realize there is this market that is just hungry for music therapy and other services that really could benefit children. Could be a real difference for them, that could really ultimately help them to be more included and ultimately ready for work when they're old enough and get their minds thinking that way.
I also think the other piece to that 77% is those are youth that do have access to some services, right? While they're waiting, right? So, for me, that's helpful to know that they do have access to those entitlement services through DOE. And we have some great, partner agencies, advocacy orgs that can support families and advocating with schools for those services. So I think that's an important piece to remember too. Certainly. And if they happen to already have Medicaid, they've also got EPSDT or early periodic screening, diagnostic and testing.
It's interesting to me because my daughter was probably 6 or 7 when we got on the waiver, and I don't know, 2004. We gave it up when we moved to South Carolina, came back to nothing, which is fine. I mean, her pharmaceutical, her meds would cost us over $1,000 a month if we didn't have Medicaid.
Yeah.
But they don't because we have Medicaid.
Yes, Medicaid is a big piece for families.
What's the tolerance on the groups though, these numbers? I mean, even on the 18 plus, it's at 1,000. Yes, kids, the younger age can get services, some services in school, when school's in sessions. Like, what are is there a tolerance level where it's something, what's the acceptable level? Do we just let this keep going? I'm curious because it keeps growing, right? Each of these keep growing and it will continue and just where.
I think it's a larger question. I think
Yeah.
there's the point of eligibility. I think there's appropriateness of waiver supports. And some of this is, I mean, I go way back. For those of us that have been around for a long time, and Kim, you've referenced this, there was a point in time when we had tens of thousands of people on a wait list under the old DD waiver. That family support waiver was the preferred avenue to address that came from stakeholders, that everyone get a little bit rather than a lot of people having to wait 10, 12, 15 plus years to get access to that DD waiver. So now what has happened, and I'm going to get on my little soapbox, but we do have folks that gratefully and should have had, have access to a family support waiver. And now it's like, but I want more. What else is out there? The only avenue that we now have is CIH. And to the point that you just saw, we have a lot of people applying that don't meet those emergency or priority categories, the way the system was designed. Holly's gonna talk about waiver reset. That's why we are looking at that now, to your point. We've got to look at doing things differently because the current model is that we're going to continue to see that. And what is the stress point? So we have to look at a lot of this. How do we support children? How do we support individuals with complex needs? And, we're going to talk about that. How do we have an array of services that truly supports individuals holistically? And we have to address capacity issues. And I don't just mean fiscal capacity in state, but there are limited people resources and all of those things. And Kim knows I get really passionate about this. How do we talk about need versus want? When we know there's a limited piece of pie, we want to support people. That's something I'm personally passionate about for 30 plus years, to be truly a part of their communities and support their families and keep them intact. But we recognize we can't give everybody everything. So how do we get there? So that's really part of Derek, wonderful questions. And Karen, to your point, that's why we are so targeted on waiver reset. And it's not a nicety, it's what has to be.
It's a necessity. I do just want to, I guess, put a finer point on your 99% of the people who are assessed are eligible. That is who is on the wait list.
Yes.
So they're not waiting to be assessed to determine if they're eligible. We've assessed them and 99% of them are eligible and they're on the wait list. So that is also why
That's part of it
the
too.
level of care evaluation kind of and activities around that are important.
Thanks.
Holly, do we track how many people in the 0 to 5 category are currently in First Steps?
I don't have that data right now, but we could look at that. Absolutely.
I think, and someone's made the statement, that's one of the things, within the division, we are blessed in this state that we have the Bureau of Rehab Services, we have Bureau of Child Development Services, First Steps, and we have our Bureau of Disability Services. And so Christina Commons, the director of the Bureau of Child Development Services, or First Steps, and I have been having this conversation as we see so many applications, birth to 3, birth to 5. How do we think differently about First Steps? And are there some possibilities there as well? So really looking at this, not just siloed within the Bureau, but across the division.
Can they get both services?
Yes.
Oh, yes, and they do. Yeah.
Absolutely.
First Steps is such a limited amount of time.
Mhm.
A lot of times, by the time they get on, it's almost time to start transitioning off. Very few kids get on like right away, unless they're very complex or very obvious disabilities, right? At least that's what we find. And so by the time they get on, they're trying to connect them fast and get some good services, but then it's like, and now we're starting to transition you back. First 3 years, as we know, go fast.
In my experience, First Step is a handoff to school.
Yeah,
Mhm.
exactly. The important part of that
Preschool.
isn't necessarily the services, it's the federal requirement that Part B hand over to Part C and Part C hands to Part B, and Part B starts services prior to them going into the school age. So it is the preschool kind of handoff that is for us, the important piece.
Yeah.
Okay, I'm gonna get us.
Holly, we know
Okay.
you always.
I know. One real quick thing to point out before we move to the next slide is that inviting of 150 people does not include those individuals that meet priority criteria on the FSW. So it's not stagnant, right? Because we have people who are 18 to 24 years of age, finishing their education, that have direct access into the family support waiver. We have children of active or veteran from the U.S. Armed Forces and National Guard. And as of July 1st of this year, we have individuals being served through the health and wellness waiver that lose nursing facility level of care. If they meet ICFID level of care, they can move to the family support waiver. So just a reminder that it's not that there isn't any growth in that family support waiver and the people being supported through that waiver. We still move people right in when they meet those priority criteria. So don't want to lose sight of that. Hmm?
I want you to say what you just said again. Those people who lose nursing level.
Oh, for individuals on the health and wellness waiver that lose nursing facility level of care, they have access to the family support waiver if they meet ICFID level of care.
So why would they lose nursing?
If their needs change, so the nursing facility level of care is really focused on medical needs and that sort of thing. So people,
Feeding to.
yes,
Or something like that, then they don't need that level.
we see people's health improve, their health situations improve, and we wanted to make that available. Yeah, Kelly, did you have something?
Well, I would say needs change, but also as was put forth way back when, and we talked about the Medicaid forecast variance, some of those strategies. We talked to you about level of care and assessment. Also, we really needed to take a hard look at the assessment process for what was the Asian disabled waiver, now the health and wellness to which we're referring to that category. Specifically, again, that tool was not designed, children were not in mind, if you will, decades ago. I'm gonna say that when all of this was being devised and developed. But thinking about nursing facility level of care. So the tools are directed at adults. And so therefore, again, I'm not saying people don't have support needs, but we had, I would say, I'm going to use the word significant number of children who may have been found eligible at nursing facility level of care who truly are not. There may be the ICF, the ID level of care need. So again, it's more of a rebalancing and ensuring that people are appropriately tethered to the supports needed. So it would be two-pronged.
I was just curious if it was a change in this recent change of that waiver, if that was causing people to be.
It was in recognition of that.
But it could be just because they developed and they're just don't have as high needs.
And we have always seen, even prior to July 1st and the waiver transition, we've always worked closely with Division of Aging on individuals that they were supporting through the old age and disabled waiver that also met our eligibility. So, there have always been individuals that may transition between those waivers and lose nursing facility level of care because their health has improved. Especially some of the younger population, maybe with 80 plus.
Yeah.
It's those,
And
so-
Holly, I was also going to add, I like that you highlighted that in addition to the 150 every month targeted off the wait list, those priority categories, there's about 370 individuals thus far this year.
Mhm.
So when you do the math, that's another 40 per month that are, if I averaging that out, that are invited to the family support waiver. So
In addition to the 150.
In addition to the 150.
So closer to 200 individuals per month are being added to the family support waiver.
Yep. Okay, next slide. Just a snapshot of MFP, how many are active, how many individuals are active on MFP. Now you will see MFP-CIH. That is just to signify those 165 individuals on MFP are expected at the end of their eligibility for MFP to transition to the CIH. Okay, that's just kind of how we've got it organized so we can track those individuals. And then we have 89 individuals transition from MFP to CIH by the end of the second quarter of this year. Quick snapshot of our supervised group living. That currently supports 2,651 adults. And we have a vacancy rate of a little over 10% in our supervised group living.
I feel very strong about this one. The 89 people is something you should always celebrate.
Yeah.
That it's 89
Absolutely.
Institution.
And remained out of.
Named out of an institution.
Yep.
Have successfully transitioned back into hopefully their home community. I just think that is just always something, I know we celebrate very highly with those. I see those numbers every month, and give great shout outs, because that's not easy work, and it's a huge transition for some individuals, who've been in institutions for years. So.
Yep, thank you, Karen. You're right.
Yeah.
Yeah.
Yes, I'm sorry, continue with.
All right, next slide. We have included here some information on the health and wellness waitlist invites as well. As many of you probably know, there is a website now that where you can go and see very current information and updates. Since July 1st, we have invited 402 individuals off of the health and wellness waitlist. 280 of those individuals were on that wait list and pulled off based on their level of care date. 54 came from a nursing facility, 37 from a hospital, and 31 from choice. So again, we are inviting 125 individuals a month to the health and wellness waiver. And are continuing that. And you will see, if you look at the website, and I think I talked about this last month, you'll see we've actually, looks like we've invited more, because there are situations where we invite 125 and some people decline, or unfortunately they've moved out of state or they've passed away. And we are pulling that slot back when we know someone isn't going to use it and re-inviting someone else. So it's not a 125 a month if you look at the numbers. So
Holly.
And can I add to that, to the pathways piece, that's the health and wellness.
Yes.
And Karen, to highlight for you, on the pathways waiver, those that are 60 plus, in those 3 months, there have been 2,636 invitations sent for that waiver. And as you talk about the transitions, I want to celebrate that, 193 of those were direct transitions from nursing facility and another 44 from the hospital. So, discharge that typically would have gone into an institutional model or institutional care. So I'm sorry, I just wanted to celebrate that a bit.
Yeah.
No, that was great because that helped a little bit. Because I was going to ask where can we find information about what sort of hospitalization qualifies for that priority care category? Is it specifically if they would be transitioning to an institution? Or are there other circumstances surrounding a hospitalization where they're being discharged and might be considered for that priority category?
if they are in a hospital, then they would have priority status.
Right,
Is that
but
what you're asking? I'm sorry.
Yes, but are there any parameters around a hospitalization? If someone's hospitalized for 2 days versus 30 days or something?
Oh, I see. I see. No, they're admitted to a hospital and ready for discharge.
So any duration, there's no, okay. Is there any circumstance for admittance? I know this is, we're just getting these questions from families.
Sure.
Is there any circumstance in terms of why they were admitted? Like if it was a planned admission or it's really due to their health, something like that? Are there parameters around that they would, like my child, for example, had a planned admission for a procedure he was having and then had to be discharged a couple of days later. Would that then consider him a priority category?
No.
Right. So that's what I'm asking her. So where do families find that information?
So we have the information in some of our FAQs. I can look and find the exact one. And try to
Okay,
get that
I've
to
looked
you.
through some, so I would.
Have you, and you haven't seen that? Okay.
Not specific to
Okay.
the hospitalization circumstance, but I could have missed it. So if it's there and you could share where that's at.
Sure,
that would
because
be
there's a
amazing.
lot of information on the website, so it's a lot to go through, but we can check on it.
Awesome. Thanks, Tom.
So invited off the wait list and they're from the hospital, so they were already on the wait list before they went to the hospital, is that what? Okay.
Do the hospital social workers know about the emergency?
Yes.
Because I know I work in a hospital and we had an incident where we had a disabled person, no guardian, no nothing, and they had no idea what to do with it. And so we ended up keeping them for months until the hospital got guardianship over.
The hospital got guardianship?
Yeah. So how, and I didn't know what to say.
you know, I'm like, why are they not getting hold of case managers to get them on a waiver? So I
Mhm.
get faster than nurses.
Mhm.
So how do the social workers get the information to know about these waivers? So apparently there are some that do not know anything.
So there's a couple different ways, but I think the key to knowing about the health and wellness waiver is though that front door right now is that area agency on aging or aging and disability resource center, which generally hospitals are pretty knowledgeable about those, but
So,
okay.
no, I think we need to probably evaluate
Mhm.
the level of
Sure.
knowledge and awareness. Especially if somebody is not accepting a social worker who is there to help with that transition of care.
Mhm.
So, because some people will say, no, I don't want a social worker.
Mhm.
But I don't, unless we have some more data and metrics, I don't know that we can say that.
Yeah, so a little bit further in, and I'm gonna have to speed this up a little bit, but there are some changes coming July 1st of 2025 related to what entity does nursing facility level of care assessments. And I think there's an opportunity there to ensure that hospitals have information on where to go, because we will have one vendor that will be doing that nursing facility level of care, and that vendor will be statewide.
You can educate. Can I
Mhm.
educate? Okay.
Sure.
We're all, I can say for sure.
Sure, absolutely. Yeah.
I would also suggest reaching out to the council and any of our other family advocacy organizations to help provide
I know it's happened a couple.
training and education.
Yeah. You know, I think hospitals have staff turnover just like everyone else and staffing challenges just like every other industry. So anytime we can help get information to them is a good thing. Yeah, yeah,
No.
yeah, absolutely. Okay, I'm gonna, oh,
Holly, you have a little bit more time because I don't think Kyle needs both.
I don't.
FYI.
Kyle, I'm always stealing Kyle's.
Yeah.
It's true.
Yeah.
This place on.
That's from Kyle. That's from Kyle.
That's from him.
I can be brief, I promise. Okay.
In case no one's ever noticed, Kyle is very easygoing and very kind and gives a lot of grace. So, and I personally very much appreciate that. So, okay. This is familiar. We talked about this last month, but I just want to keep this available for everyone. Kind of talking about where we've been with regard to our home and community-based services waivers. If we go to the next slide.
Too fast, Holly.
Oh, sorry. Yeah, I gotta speed it up. So, this is a proposed waiver amendment timeline for 2025. So we did, again, we talked about this some last month, but we had some questions and I just wanted, we had limited time last month, so I wanted to bring it up again. That we are, we'll be working on drafting another waiver package, so to speak, to submit to CMS in March for a July 1st effective date. All those will go out for public comment and tribal comment in January, February timeline for that March submission. The July, again, waiver package term, it will include amendments for the pathways for aging, the health and wellness, and the TBI waivers. And that is for implementation of a pediatric nursing facility level of care tools. And for level of care assessment representative, commonly referred to as LCAR. And that is the entity that will, in July 1st of next year moving forward, do all nursing facility level of care assessments. Hospitals are familiar with the vendor that will be doing that, which is Maximus, because that is the vendor that does nursing facility level of care for our pre-admission screening program. So today, if someone's in a nursing or in a hospital and they are seeking nursing facility placement, hospitals help facilitate that assessment. It is the same vendor that they contact about that. that they will be contacting about waiver level of care. So I think that might help some. We hope, because it's again, a familiar face, so to speak. So in July, those amendments, or we'll be submitting those amendments in March. With those amendments, we will have renewals of the family support waiver, CIH waiver, and the associated B4.
So are there amendments to each of the type of waivers?
There are
Or just the three
amendments,
that you said?
just the three for, that will go in March: pathways, health and wellness, and TBI. And in that waiver package will be renewals of the family support waiver, the CIH waiver, and the associated B4, which allows us.
With no amendments, exactly as they are now.
They're going to be straight amendments. There are adjustments to, or straight renewals, I'm sorry. We will have to include some additional updates on the waiver years, some data, but there's straight renewals.
So no enhancement of those three.
Not for July. One effective date. No planned. Now,
We've
so-
been kind of hearing since 2019 that there would be changes.
sure, well, that's a really good question, and that's why I wanted to mention.
She's lucky for her first day.
Yeah, she's good. Lots of good questions.
There are
Lots of good questions.
It's great, it's great.
Yeah. So we will be submitting or intend to submit another set of waiver amendments in for effective date in November of next year. Now, some of those, that will be across the board. That will be all the waiver amendments, kind of not dissimilar to the package we sent that just went effective July 1st, because it will be amendments to pathways, health and wellness, TBI, family support waiver, and CIH waiver. And those will include potentially some further alignment in terms of our service definition. So there's a couple, as an example, structured family caregiving is available on the health and wellness and TBI and on the CIH, but they're very different, right? So we have to get those aligned. So some of that cleanup we will be doing and further alignment for those amendments in November. Now, when you said you've been waiting since 2019, is that what?
That's what I think.
Yeah, and that's okay, because what we started waiver redesign in 2019, right? And that might be
So
captured
a
on the
lot of those
previous slide.
parents think that this July 2025 is when.
It's
No,
not.
the target date.
It's not. Yeah, I want to be really clear about that. Those November, the amendments we're doing or will be doing for implementation in November, pending CMS approval, are not waiver redesign. They are really some things we have to button up from this waiver transition period. And some things we need to further clarify, but they are not, it is not waiver redesign. We've kind of, I don't want to say we've moved past that, because we're not forgetting all that. All of the work that we've done and are doing in terms of gathering feedback from our different partners and individuals and families, all of that is still preserved and will still be used. But we're really looking at more of a waiver reset. And that's not going to happen in 2025. We are still with the waiver transition, we're serving a whole new set of individuals that we are engaged with, but not at the same level that we have been engaged with individuals and families that we have traditionally supported in beads. So we're really looking past November of 2025 for a waiver reset. How can we design a home and community-based services waiver system in Indiana that recognizes the needs of all the individuals beads is supporting now, and make that system flexible to support individuals across the lifespan and across different needs and abilities. So waiver redesign isn't over. We're just transitioning to waiver reset now that we're supporting more people. So all of that is not lost.
And I like to say the difference is we're going to do away with this constant tweaking. Minor change, minor change, minor change, minor change, minor change. We're not really effectuating what we've heard from stakeholders that they desire. And so that's that movement toward the reset. You know, at the same time, we did, integrate 2 new populations under this division, but that's not really the total reason why we're doing it.
No.
It is those things that we talked about. The current system wasn't designed with children in mind. We currently have an FSW or an emergency placement waiver. So what about in between? We have some services available over here and not here. So really looking at the whole, that's going to take some time because we are talking about, to your point, Holly, it's a new way of doing things. So it will be thoughtful and deliberate. You're going to talk about the timeline. We're not talking about way down the road, but we are talking beyond 25. So.
May I ask a question?
Sure.
I thought we were going to do another amendment this fall around self-direction and peer mentoring.
That's for the November 25 implementation.
Right. So,
Oh,
and it's going in March, or I thought there was.
No,
one
the
going-
March, what we submit in March will be for an effective date, July 1st. And
Okay.
that is going to be renewals of the FSW CIH and amendments to Pathways Health and Wellness and TBI for the new pediatric nursing facility level of care tools and the implementation of the level of care assessment representative. Then we'll be putting out another waiver package of amendments for public and tribal comment in May with an effective date of November. And our intention is to include the self-direction in that.
And
in that-
nothing more this year then.
Correct.
Okay. And so and peer mentoring is a part of that too.
Peer mentoring, maybe, but I don't necessarily see that as a for sure thing in November. But that is something we are holding on to for sure with the waiver reset. And in fact, I have some slides as well on the 1102. I don't know if we could kind of skip to that a little bit.
You want to skip, Holly?
Yeah, let's go ahead and skip to that a little bit, just because we talked briefly about 1102, some of the recommendations last month, but in some subsequent conversations, I felt like it was worth talking about again. Many of those 1102 recommendations were completed or determined completed by the committee, but I wanted to emphasize that those recommendations, even if they've been completed, those are still part of what we think about when we think about waiver reset, right? Like there were some things on there, and I'm not going to go through all this now just for the sake of time, but we look at housing support, shared living models, some things that we have innovation pilot projects around. I see I used an acronym there. I'm sorry. IPP is innovation pilot projects. All of those things are still on the table for waiver reset. And we have that opportunity to really get some additional feedback, as well as look at the feedback we've received to date about what that housing support, as an example, should look like, right? What is it that individuals need when we start talking about housing support, and how can we take that feedback and work towards designing that particular service, again, as an example, that would better support individuals. The shared living models, we've got some innovation pilot projects around, as well as lots of other services or different ways of delivering services that already exist. So again, I wanted to mention the 1102 because of some subsequent conversations. Peer mentoring or peer, if we go another slide, is also in this list. Peer support, there it is. And there, of course, VR uses some peer mentoring, but to your point, Kim, or to your question, that is still something that we have heard loud and clear that people are interested in. We use it with our MFP program, as you know, our Money Follows the Person program, but how can we expand that as a service as part of waiver reset? Does that help?
Yeah.
Okay. All right. If we can go ahead.
Here, Holly. Right?
Okay. Yeah. I want to go back to this just because I wanted to mention, as Kelly said, we're not right now thinking about doing lots more tweaking, so to speak, to our waivers after we get through November of 25. But I do want to stress there are still opportunities for us to look at how we can reach some further alignment in areas of how services are delivered, case management. You know, what opportunities do we have before waiver reset where we could really look at our case management services and how those are being delivered across all of the waivers, our eligibility assessments, where can we find some alignment there? So these are things that we'll be looking at, and IT system changes, which may not be particularly interesting probably to a lot of us here, but as we think about IT systems, when I say that, what we're thinking about, how can our systems that our case managers use, our providers use, support their work with individuals and families and enhance communication. And I'm going to take 2 minutes to just say, we got word today that the BEADS portal is now officially CMS certified, which is a huge deal. We are super excited. I'm going to be wearing a smile probably for a long time, just because that's a big accomplishment. I'm sorry.
That system, yes.
That's a fabulous idea, and
I would be a hero if I could go back to our staff and tell them they did not have to use the other system.
I'll just say stay tuned. Okay, just stay tuned. Because to Karen, what Karen's referencing is care managers, case managers on the health and wellness and TBI waivers use CAMS as their IT system to support individuals receiving waiver services. And the FSW and CIH uses the BEADS portal. And if they're
Insight looked lovely.
yeah, if the BEADS portal and CAMS were put in a ring together, the BEADS portal would for sure win. We'll just say it that way. So anyway, just quickly, there's still, again, those areas that we've identified where we have opportunities for further alignment. So Jessica, if we can move on through.
Anything else?
One more, keep going. If there's questions on some of these, we can feel free to reach out. Next slide. I want to get to this. So there's an acronym with no explanation. So that is the Special Services Review Team. Our new acronym, SSRT. So there was legislation and there is Indiana code now. It's listed there if you want to take a deep dive. That establishes the Special Services Review Team. The scope of that team is to review denied CIH applications for districts 1, 4, and 8 for the time. Well, that's our I'm not great with directions. Northwestern part of the state, our western part there near Terre Haute. Thank you. It's so helpful. And then southern part of the state, southeast part is where our District 8 is, down near Louisville, Kentucky. And the Special Services Review Team will review denied CIH applications for those districts for the time period December 1st of 24 through July 30th of 25.
I have a question.
Yeah.
So is there a person with a disability on there? And if not, why?
Yeah. Trying to think through the members.
I don't think we wrote that in.
That wasn't in the
That
statute.
would be nice.
Yeah.
The same.
Yeah.
Well, Sean, I will tell you, we did seek and invite an individual who declined, a person with a disability. So there was an attempt made, but no, there's at least an individual has not identified as having it.
Right.
No, but so even though not mandated or required, I would like to say that we actually did seek that, but we are a bit under a timeline and.
Sean, are you saying you'd like to be on that?
No.
I
do enough stuff. No doubt.
Just get you some more tea and you're done.
Yeah.
Come over and hang in your basement.
So I think it's a good point, but I
Yes.
just want you to know that there was strong consideration, lots of discussion, so.
So again, if you can go back one more time, that's okay. And really, I want to stress the purpose of that SSRT is really to evaluate information and provide information and data to the division director that could inform our review process. You know, what those denials look like, what those individuals submitting requests, what their needs are, what their stated needs are. It is not, the committee or the team does not review, like those decisions generally have been made before that team sees that. So this is not a team that would change a decision on a CIH request, as an example. It's going to provide information. It's really more of a pilot study research that will provide some good data for us moving forward. Next slide. Okay, so we've talked a little bit about waiver reset, and I'm gotta stop talking soon, but we'll continue to expand our engagement opportunities as we continue to navigate towards waiver reset. But just want to highlight a couple things here. The provider and case management webinars monthly are occurring. Those are opportunities for us to provide information and guidance to providers and case managers, but it's also an opportunity for them to ask questions and us to be able to address those questions, if not in the webinar, after. The other are building bridges. So these are the events where we go out in the community and invite individuals and families to come and just talk to us about what's working, what's not working, what the gaps are, what their experiences are with our services. We released information or a schedule of when those are happening and where. I can't remember. I think it was earlier this month or in August we released it. I can't remember off the top of my head. We've had one. We had one this week. And in no way do I want to give the impression that it wasn't good, because it was, but we had one family member show. So if members of this group can please share these opportunities with individuals and families we support, we would appreciate it. We will travel anywhere in the state. We have to stay in the state, anywhere in the state to meet with individuals and families. And it was by far worth it. The gentleman we talked with provided us some very good information and feedback, and we would do it again tomorrow. But if we can get more people, more individuals and families to know that we are there for them to talk to and share whatever they want to share with us, if you all can help us with that, we would really, really appreciate it.
I think also, just to further kind of plug what you're doing, these aren't presentations.
No, they're not.
I mean, they
No,
are
these are
sit down,
listening
kind of table conversations with people where the families, individuals who are attending are driving that agenda, not us. And so if people are thinking it's just, I don't want to go to another state presentation, I don't blame them, but also this is not that. This is something I think very different, a different kind of opportunity.
Well, as a person who was the only one to show up when they came to my city 2 years ago, it was extremely beneficial.
Yeah.
It was a fantastic conversation. So I agree. Like, if families can get there, it's well worth it.
Thank you for adding that. I wanted to amplify, Holly's message. And, you said the last one, there was one individual. And to your point, I would like to stress that historically, we've seen some small turnouts like that. And we want to hear from individuals as we're planning, putting people at the table, not when there's concern about a decision now made. And so I think any feedback, any assistance that we can get to get people at the table would be most appreciated.
See if I can load up Mitch Daniels' old.
The boat. That'd be great.
What were the barriers? Was there any kind of discussion around what the barriers to people participating in those were? Any kind of brainstorming on what they could be, why people didn't show up? ideas, that time or?
We have tried different times. It's usually evening. But we've also done some in the later afternoon historically. We are doing some virtual. We never did virtual until after COVID. But
Yeah.
after COVID, that seems to be somewhat helpful, but it isn't the same as being for a family to be able to sit there and just say whatever they.
Evening times for families are, if they don't have the support,
Mhm.
evenings are obviously dinner routine, nighttime routines, if there's some
Sure.
childcare. I mean, I can think of a handful of barriers off the top of my head that would prevent me from going to something like that. Is there any discussion on how to reduce those barriers or partner with like, I don't know, council to help reduce those barriers to participation?
Now, we could certainly have those conversations. We, like I said, we have done some in the afternoons. I don't know that we've ever done morning over the years, but we have done afternoon.
We haven't, and I think we typically do evenings because that's what we heard was
Yeah.
the
Oh, I
desire.
would not,
Just
yeah.
because of people's work schedules, they're
Exactly.
having to pick up kids or take them to therapy, that evenings really were where you were more free. And so that's why we do that in the evenings. I think too, the biggest barrier I hear is we didn't hear about it. And so we share it as much as we can, but if we don't have our partners helping to share it, if families don't know it's an opportunity, then they don't show up.
Well, let's talk more.
So. Yeah, so absolutely. If you can help us out with that, we'd appreciate it. And the last, yeah.
Your guys' social media too, if you see it, which a lot of you guys do, but just continuing to share it. Because I think that's a lot. I mean, that's a lot of it, I think. I mean,
A 1 hour virtual lunch one
Yeah.
time, because I find a lot more families are being forced to work. But they can schedule a lunch hour if it's something they want to participate in, but they couldn't do it in person.
I don't, were those more,
we
we
have
did
virtual.
those, yeah,
Yeah,
we did those.
We're doing both.
Yeah.
We're doing
And I
some
think
virtual and.
pre-COVID, unfortunately, they tended, they were more, I mean, when I went to two, there was 20 some people there. So, you know, it just, unfortunately, I'm not justifying that, but I just, a lot of times I think it's hard,
Yeah.
but I do think we do notice like more, and sometimes we've asked people, I think before we've sometimes asked, where did you hear about this? Because we want to know, or is it Facebook? Is it your case? We sometimes case managers. I mean, even the gentleman yesterday in this training, it wasn't building bridges. There was a gentleman there. He was a grandfather of someone in services. And I wanted to ask him, how did you find out about this? Because
Do you post evaluations like participant satisfaction surveys afterward?
no,
We don't, because we don't
want to
collect like their information. We want them to.
Collect participant information to do a satisfaction survey though.
No, but we want it to be, we want to make sure that families understand this is just their opportunity to come and talk, and we're not gonna try to find them afterwards unless they want to be found, right? Like,
Yeah.
So I think if we
Yeah.
can get people to show up.
Then we can
talk
do
about
that.
Doing surveys.
Yeah.
Okay.
But let's get some people to actually be
Right.
there so that we can talk about
Yeah.
how we
Yeah.
might get feedback.
And I think if you guys are hearing someone say, I can't, like, I had
Right.
someone email me that says, I can't get here. Literally, I talked to this woman and said, how can we get you there? Like, I don't just say sorry. I say,
Right.
do you have, so, but I think sometimes like people just, I'm not saying we do, but like, if you take that extra step, like, hey, how do we get you here? Or maybe there's another one that's a little bit closer. Cause I think that is a barrier. Transportation's a barrier. For sure.
Yeah.
But I think just trying to figure out, because people want to help, other people want to help, like people want to help people. I really do think that. I just think it's like, we have to take that next step too, so.
Okay, can we go to the last slide, or my last slide? Sorry. Just wanted to make sure this group was aware. We have been notified that the Office of Inspector General will be doing a audit in Indiana. They are doing this in other states. They did Missouri in 2023.
So this is not Indiana's Office of Inspector General?
No,
Okay.
no, this is Department of Health and Human Services.
Okay.
Yeah, yeah.
Federal
So, yes, the federal level. So they are doing an audit where they are going to look at our procedures and monitoring practices of our waiver providers that are providing residential habilitation to individuals receiving that residential habilitation through the CIH waiver. They will be doing unannounced visits to individuals' homes and providers. So we will be sending out a letter very soon to all residential providers to let them know that you may get a visit from a team from OIG, and they will have their IDs, badges, I don't, and will be expected to be asked for those, but we, again, will be notifying all providers that provide residential have on the CIH waiver, but not all will be visited, obviously. But just wanted to make this group aware that is happening.
No, it's just residential
No.
through the CIA.
Are they gonna do like the roof behind stuff like they used to?
October.
These are
Visits are planned in October.
starting in October. Starting in October. This is really a health and safety
Yeah.
audit.
That's the focus.
So they're going to be looking strictly at health and safety and how we've monitored.
And it's unannounced, Holly, to the providers.
Unannounced to
Yeah.
everyone.
Oh, yeah, you
To
said
the
that.
individual.
Yeah.
provider.
Knock on the door.
Everyone.
Yeah.
They will just show up and say hi. So.
What's that? Yeah.
So anyway, again, just wanted to make this group aware in case you hear from a provider that they got this letter. So, anyway, so I'm done now and I took all of class. One day Jess is gonna put me at the end so that when the time is up, you all can just start walking out and give me the message. So,
Yeah, we did work it out. I did talk to Kyle.
thank you
Yeah.
guys. Thank you. Sorry, Kyle.
Oh,
Nicely done, Holly. Thank you.
all right, so I'll be.
Might have questions during the parking lot, so
I'll be great.
I will be very brief. I just wanted to share some updates on a couple of upcoming efforts that we have planned related to alignment of our employment supports across the division. The first, in October, we'll be attending the State Employment Leadership Network annual meeting. We're fortunate. I'm really excited to be able to send a small cohort of staff from both our waiver program and also our vocational rehabilitation program. We were not able to send VR staff last year. There are 25 member states in the State Employment Leadership Network. We're one of 7 that is sending vocational rehabilitation staff. So really fortunate to be able to do that. A couple of topics that we anticipate that are, I think, really timely to our discussions today and what we have planned for the next year. First is really digging into evaluating the role that day habilitation services can play in competitive integrated employment outcomes and kind of dealing with what's going on right now at a national trend level. And the second one is around really enhancing alignment of state waiver services and state vocational rehabilitation services, all towards that same goal. So really, I think timely. I hope to be able to report out at our October in-person meeting some of the information shared and perhaps some of the things that we have learned in discussion with other states who are also present. The second, as a reminder, I think you remember when we were discussing the employment collaboratives, the 2-year employment collaboratives, one of the requirements for participating in those collaboratives was to target and document at least achievement of competitive integrated employment outcomes for at least 4 individuals. Providers have all that information in terms of the reporting structure, and they're reporting that data out now. So beginning in October, we're going to start aggregating and analyzing that data to kind of look at trends, look at things that might kind of pop out that are notable. We anticipate being able to share some initial information around that data at our November virtual meeting. And then we are also, planning on drafting a full report on that aggregated data with a target for the end of the year. So just a couple updates. Any questions? If not, I will pass to Jessica. Is that correct?
Yep.
All right.
Sorry, the webcast is gonna end a little early, because of 2 other meetings that FSSA has, so I don't know if that's gonna end the Zoom, so I'm checking with you guys, Katie and Noah. I think you'll be okay, I just don't know that it's the Zoom, so just FYI. Hopefully not. Okay. Sorry, I realized that. Okay, Kelly, you wanna do I didn't put a slide
Yeah,
for it, but talk about the
fine.
dual diagnosis a little bit.
Just want to do a brief update. I think I mentioned last month, one of our innovation pilot projects is partnered with one of our other ARPA funded projects that was around dual diagnosis capacity building. So that project, the dual diagnosis capacity building project, has funded, supported statewide training around positive behavioral supports and how do we better support individuals with complex needs in our communities and in their home setting. So actually, our trainers are in the room today. Jim Wells is in the back of the room, Kelly Hartman. And you've, actually, there was just a training here yesterday on site. How many folks?
Yesterday, we had about 60.
Yeah, so 60, we've had some of the folks register 100 plus.
100 or something.
Yeah.
Yeah, yesterday parking for some reason was especially difficult because one of the parking garages that's open usually was closed.
Well,
So
that's
people circled for like an hour trying to find a spot, but we've had one in Fishers. So the 2 District 5 trainings have happened. One was last week in Fishers, one was yesterday here, and they were really, really well received. And it's specific to dual diagnosis and using positive approaches as opposed to the old restrictive behavior
Let's
mod
take things
approaches.
away.
Yeah.
But you're right. I think the important thing too is like you told us, you related to, you know, a grandfather of an individual was in services there yesterday. So we're looking at training direct service workforce, state personnel. Actually, I was
There was
sharing
no
with Jessica.
no
Yeah.
MPP staff member was there.
Locust Force Hospital.
We have folks from our state hospitals. So when I talk about this dual diagnosis capacity building, this is one arm of it, one of the trainings to launch this. We worked with NASDs, which is the National Association of State Directors of Disability Services. NASDs.
Longest acronym.
It's the longest, NASDSS, it's the longest acronym ever, but they had an institute. It's actually a dual diagnosis capacity building institute where we had access to subject matter experts. So in the first year, we did some internal training and analysis, but also working with some of their technical experts as well. We are looking at our policy and our system as a whole, and not just within our division, but how do we align across the state? So I was just sharing with Jessica, Dr. Maria Fennell, who is our chief medical officer with FSSA. She wants to attend. We want members from across DMHA to participate in this because it truly is looking at how do we support people, trauma-informed care. I know that's an overly utilized term, but it really is significant. Trying to understand a person's history. It's like, what are we trying to communicate through our actions? I hate the word behavior. I don't even like to use the word behaviors because I'm having a behavior right now, right?
Never about to.
Yeah. So that is part of what we're teaching. So it really is foundational. We want to build capacity, if you will, expertise within the industry, and then it comes to the front line. And this isn't up to some specialist to write a plan. This is how do we engage with people in a day on a daily basis as individuals in their lives, whether we're a support worker, a family member. And so part of that waiver reset then is how do we better define and serve people through whatever we call it, behavior management, behavior consultation, whatever. How do we do a better job? We've got some great individuals out there, highly skilled. And how do we effectuate that and do this in the appropriate manner to better support people with complex needs? And I'm going to give a shout out. Part of the reason I want you to know is that we've also been very thoughtful and deliberate as we are looking at appointments to this council. And I don't mean to call you out, but one of the reasons that when we looked at a provider representative, Anne came to mind, she came to my mind, I think the Hollies. She doesn't tout her horn as loudly as she should, but she has a long history and successful history of supporting people with complex needs, as do Kelly and Jim. So bringing those folks to the table and trying to invite others to the table to understand how we might do this better. So more to come, Kate, we're gonna be talking about this with Governor's Planning Council, because this really is a systemic change. This is one of those things we can't, it's not a tweak.
So
We have to change the culture, and then we have to have the services in the system to support it.
And so in addition to the state trainings in each PDS region, and we had 2 in central Indiana, we're also working with 6 providers or provider collaborations across the state. And doing this specifically for DSPs and people who touch the point of service delivery. And so that's been exciting to see
Yes.
providers who are willing to collaborate, who typically are competing, right, and really come together.